Evening, respected Professor Sir, and my dear students, I welcome you all to another session of RISA DNP Online Academics today. We have Dr. Sonaxi with us now to start with the presentation. Over to Dr. Sonaxi.
Thank you so much, sir. Good evening to all. I'm Dr. Sonaxi. Will be presenting the topic anesthesia and neonatal emergencies. This begins with preoperative assessment, which includes a brief history and quick systematic assessment of the neonate to rule out major illnesses. Parameters to be assessed includes fluid intake, urine output, gastric or feeding tube aspirations, drains if present, any temperature and other vital parameters, time of last feed, micturition to be noted. Brief physical examination includes post-conceptional, postnatal age, weight, hemodynamic parameters, respiratory rate, temperature, status of hydration. Cry, tone, activity of the neonate should be noticed. Hemodynamic instability in form of cold peripheries, feeble or absent distal pulses, poor capillary refill should be assessed and treated. One should look for the evidence of respiratory distress like grunting, tachypnea, labored breathing, and we should always check saturation in the preoperative holding area. Degree of abdominal distension and amount of gastric tube aspiration should be assessed. Any evidence of sepsis should be ruled out, especially in abdominal surgeries. Sites for peripheral and central venous access should be checked. The basic minimum investigations include hemoglobin, blood urea, nitrogen, serum creatinine, serum electrolytes, blood gases like ABG, BBG, platelet count, especially if there is sepsis. Coming to preoperative preparation, this begins with informed written consent from the parents and pre-medication. Pre-medication usually reduces anxiety and facilitates compliance at induction. Uh, Usually, we use per oral midazolam, which is commonly used. And as a rule of thumb, vitamin K is usually given to all the newborn. Coming to preparation for induction, this starts with OT preparation, operating room preparation. First, warming up the OT to appropriate temperature because newborns are most prone to hypothermia. So, adequate temperature to be maintained is between 28 to 32°C, and warming devices like warm blankets, radiant light heat source must be kept. Anesthesia equipment table includes anesthesia machine checkup, monitoring equipments like precordial stethoscope, pulse oximeter, ECG, capnography, anesthetic gas monitors, appropriate size of BP cuff, saturation probe, temperature probe, face mask, oral and nasal airways, LMA if planned. Three sizes of ET tube with stilette, suction catheter, and NG tubes must be kept ready. Warm IV fluids must be kept. IV cannulas and padded or foam head rings should be kept. Coming to induction, IV induction is most commonly used in emergencies. The induction agent of choice being propofol with 3 to 5 mg per kg with 1% of lidocaine. If using a small vein dilution with dilution of propofol with an equal volume of 0.9% of NaCl, significantly decreases the pain on injection site. The signs of anesthetic induction in a sequence includes the appearance of nystagmus, eye closure, the respiration becomes slow, regular, deeper, followed by a shallow and more rapid respiration. The child becomes still. The child may have fallen half asleep and responds to verbal commands until the child no longer reacts to one's voice and the eyelash reflex disappears. Nothing should be done to stimulate the patient. An IV dose of atropine like 0.01 to 0.02 mg per kg is to be given to infants to prevent bradycardia. ET tube intubation is indicated, preferable to use rapid sequence induction in full stomach patients, that is newborn at risk of aspiration in cases of intestinal obstructions, NECs, etc., with a normal airway on physical examination. After appropriate fluid volume resuscitation, pre-oxygenation, pre-treatment with atropine, IV thiopental or propofol, scoline, and with application of gentle cricoid pressure, ET tube is inserted. One should avoid hyperinflation, repeated gastric suctioning, and appropriate anesthetic depth should be maintained to reduce the risk of regurgitation and pulmonary aspiration. One of the main points to be kept in mind is ETT fixation, which is crucial. Neonatal trachea is only 4 centimeters in length, and inadvertent extubation and endobronchial intubation are more common. So, a 3-point fixation to prevent the movement of tube in all the three planes should be kept in mind. One of the neonatal airway emergencies, which include is laryngospasm, which is more common in children. Additional risk factors to added risk factors include the inhalational anesthetics, asthmatic patients, URTI, and chronic lung diseases. Children become more cyanotic more rapidly than adults because of increased metabolic rate and oxygen consumption and reduced FRC. Uh, and so is bradycardia is a premorbid event indicating inadequate cardiac output and significant risk for cerebral hypoxia. So, uh, uh, sorry, there are two types of laryngospasm, which is a partial and a complete spasm. Partial laryngospasm management includes 100% of oxygen, CPAP, gentle assisted ventilation, and propofol at incremental of zero point 0.5 mg per kg boluses to deepen the level of anesthesia. Complete spasm management includes 100% oxygen, again CPAP. Assisted ventilation may exacerbate the condition by inflating the stomach and forcing the arytenoids and the false vocal cords against the true vocal cords. So early administration of suxamethonium, that is 1 to 2 mg per kg IV or 4 mg per kg IM to thigh with massage is preferred. Atropine 10 to 20 micrograms per kg may be necessary. Uh, One of the important points in neonatal induction is chin lift and jaw thrust to maintain a clear airway, because hyperextension often occludes the airway in neonate, and a neutral position is usually more useful. A small shoulder roll may be beneficial to achieve this. And there is we can also perform inhalational induction. Sevoflurane is rapidly acting, enabling a smooth induction, which is, and that is non-odorless, relatively non-irritant. For suspected difficult airway, sevo and 100% oxygen is used, otherwise 50% of nitrous and nitrous oxygen is satisfactory. Coming to early post-induction period, some points which have to be kept in mind is ETT, that is properly secured and provides intermittent positive ventilation. IV cannulas should be checked if they are properly secured, as often newborn emerge in an uncooperative and agitated state. Positioning, proper cushioning and gamzees with gamzees prevent pressure injuries during long period surgeries. Ventilation, controlled ventilation is traditionally used. Jackson Rees circuit for ventilation in neonates and thoracic surgery is preferred. Pressure controlled ventilation has been used in favor of volume control ventilation. Monitoring, apart from the regular monitors in major abdominal surgeries, CVP monitoring may be needed. Blood loss monitoring is very important. It is important to identify at least one peripheral pulse site, which can be monitored throughout. Coming to fluids and electrolyte management, fluids, this is divided into three subheadings. One, deficient fluid, maintenance fluids, and replacement fluids. Deficient fluids are that those which are due to disease process or preoperative restriction to orals. And there are three components in replacing this kind of fluid. Is estimation of the dehydration severity, determination of the fluid deficit type, and then the deficit repair, which is common. Maintenance fluids include these are the fluid which replace the ongoing fluid and electrolyte losses during surgery due to insensible or evaporative urinary losses. The insensible water loss includes 30 to 35% of the ongoing losses. In newborn infant, one-third of the insensible water loss occurs via respiratory tract and two-thirds via skin. And this fluid replacement is calculated by the Holiday-Seger's formula. In neonates for first day, according to the birth weight, the fluid is calculated as if the baby is more than 2.5 kg, 60 ml per kg per day is given. 2 to 2.5 kg, 70 ml per kg per day. 1.5 to 2 kg, 80 ml per kg per day. 1 to 1.5 kg is 90 ml per kg per day. Then for every day, we add 10 ml per kg per day till the fifth day. With the use of overhead warmer phototherapy, additional 10% and 20% of fluid is respectively is added in the fluid requirement. In cases of raised C-reactive protein or in sepsis, 40% of extra fluid is given. Coming to replacement fluids, third space losses in certain diseases, particularly the GI illnesses, surgical handling and tissue trauma leads to capillary leak, which translocates the fluid to non-functional compartment. This fluid resembles the ECF with small amount of proteins. So RL is the fluid of choice for the intraoperative period. And in cases of mild, moderate, severe tissue trauma, 2, 4, and 6 ml per kg respective fluid is given. Replacement of other losses, like in cases of GI illnesses, the site of obstruction and its duration determine the nature of fluid loss, and it influences the body response. Obstructions less than 3 days will have more of ECF deficit, up to 80% than of ICF deficit, and more than 3 days obstruction will have ICF deficit, which is 40%, and ECF of 60%. Replacement of the lost gastric juices to be done with 5% D.5 NS and KCl is a good choice. Replacement of blood loss, a minimum hematocrit of 40% for neonates is accepted as a safe range without the need for blood transfusion. Less than 10% of blood loss of the estimated blood volume, this should be managed with crystalloid. For 1 ml of blood loss, 3 ml of ringolactate can be given safely. Colloids like dextrons, gelatins, hetastarches are given in dose of 1 ml for 1 ml of blood loss. If more than 10 ml of blood loss for the estimated blood volume, it has to be replaced with blood. Again, temperature maintenance, the safe range of temperature to be maintained is 35.5 to 37.5 degrees Celsius. Coming to emergence and extubation, this should be carried out when the child is normothermic, normovolumic, and has minimal concentration of expired volatile agents. Neuromuscular blockade is reversed with neostigmine 50 micrograms per kg and glycopyrrolate 10 micrograms per kg. Gentle suctioning of pharynx and nostrils is done. NG tube aspiration, if present, is done. Child is extubated awake when breathing adequately and moving vigorously. Then in the post-anesthetic care unit and the post-operative pain management, for mild to moderate pain, a non-opioid analgesics is preferred like paracetamol with an oral loading dose of 20 mg per kg followed by 15 mg per kg 4 hourly, IV dose of 15 mg per kg 6 hourly, or rectal dose of if given through rectal route, loading dose of 20 mg per kg in neonates followed by 20 mg per kg 6 hourly. Maximum dose of paracetamol in neonates is up to 60 mg per kg per day. NSAIDs, this group of drugs should be avoided in patients with coagulopathy. Diclofenac, when given, should be in the dose of 1 to 3 mg per kg per day in divided doses, which is most commonly used. And for severe pain, opioids are preferred. One of local anesthetic techniques are also one of the modalities in the postoperative pain management, especially useful in the emergency situations as it decreases the need for a systemic anesthetic requirement and hastens the recovery and decreases the need for post-operative ventilation. Local wood infiltration with 0.25% bupivacaine at the conclusion of a surgery, which is very effective and extremely simple and safe to use. Regional blocks like intercostal blocks following thoracotomy, caudal blocks can be used, and epidural analgesia can always be used. Coming to specific neonatal emergencies, I have covered some of the neonatal emergencies. Coming to the thoracic emergencies first. First is the congenital diaphragmatic hernia. I'll be covering this under the subheadings of the brief procedure, the anesthetic technique, the preoperative, the perioperative, and the post-operative criteria. The procedure in CDH to be performed is to repair the defect in the diaphragm, either by suturing to the abdominal wall or with a synthetic graft. The anesthetic technique preferred is general anesthesia with intermittent positive pressure ventilation, and arterial line is preferred. Preoperative, the incidence of CDH is 1 is to 3,000 to 4,000 deliveries. 85% is left-sided and 20% are with cardiac anomalies, usually diagnosed antenatally in ultrasound. Clinical features include increased respiratory rate, respiratory distress, cyanosis, scaphoid abdomen. Usually the patient is already intubated and ventilated. Ventilator support includes HFO and NO. Nasogastric tube is essentially preoperatively put to prevent stomach and small bowel in the chest cavity from collapsing the lung. Perioperative includes cautious ventilation with the face mask. One should avoid nitrous oxide, nasogastric tube, two IV cannulas, and the right radial artery line should be put for pre-ductal sampling. Airway pressures are to be maintained at a particular range that is less than 25 centimeters of water, and we should use a respiratory rate to improve the ventilation. High dose of fentanyl, that is 25 micrograms per kg, to reduce the pulmonary vasoconstriction response to surgical stress, should be kept in mind. Post-operative ventilation for at least 24 hours should be performed, and then one should attempt to wean the patient. Infant may deteriorate within 12 hours post-operatively due to pulmonary hypertension crisis. Rarely, if the defect is minimal, one can extubate immediately. Some special considerations in such patients is pulmonary hypertension may be significant. Initial management include hyperventilation with 100% oxygen and fluid boluses. Drugs can be used like ibuprostanol, sildenafil, and nitrous oxide. ECMO is the last resort. To assist weaning, a thoracic epidural may be of benefit. Some important points in CDH to be kept in mind in delivery rooms is to avoid the bag and mask ventilation, to minimize the over distension of the non-compliant lung and distension of stomach and bowel in chest. Early intubation of trachea and decompression of stomach is helpful. Low PIP and peak inflation pressure and positive end expiratory pressure should be maintained. Tidal volume of 5 to 10 ml per kg, and permissive hypercapnia with uh, arterial carbon dioxide, PaCO2 of 60 to 65 of Hg should be maintained. Infants with severe pulmonary dysfunction may not tolerate one lung ventilation, making it difficult to use the minimal invasive surgeries. And one should keep in mind to improve the preductal saturation to more than 90% in patients of CDH. Coming to the next emergency, which is a tracheoesophageal fistula and esophageal atresia. Here, the procedure to be performed is ligation of the fistula with anastomotic repair of esophageal atresia. The anesthetic technique used is general anesthesia with IPPV and arterial line. Preoperative 1 is to 3,500 deliveries with 85% of esophageal atresia with distal fistula is seen. Diagnosed in utero. Increased incidence of prematurity 30%, and cardiac disease, that is 25%, is associated with death. presents with choking, cyanosis on feeding, and inability to pass the nasogastric tube. Constant risk of pulmonary aspiration is present in patients with TEF. So, a double human replicable tube in the esophagus is put, which does the function of irrigation and suction. Perioperative inhalational and IV induction agent, gentle mask ventilation is done to minimize the gastric distension via the fistula. Careful ET tube placement, and to confirm the symmetrical ventilation with the ET tube distal to the fistula. Uh, with the ET tube distal to the fistula, manual ventilation may be necessary to assess the lung compliance after ligation of the fistula, to assist in the repair of esophageal atresia, and to periodically reinflate the lung. Surgical retraction may impede ventilation, so this should be avoided. Intraoperative access will be needed to pass the transanastomotic tube nasally to facilitate the esophageal repair. Intraoperative analgesia preferred is fentanyl 5 to 10 micrograms per kg, or the epidural by thoracic or caudal route if early weaning is anticipated. Surgical approach in TEF repair and esophageal atresia repair is right thoracotomy, extrapleural approach. This is the preferred approach. Uh, Thoracoscopic compression of the ipsilateral lung makes desaturation more common because of the direct compression of the IVC and the right atrium, which decreases the venous return and in turn increases the carbon dioxide absorption. So, hypercarbia and acidosis is very poorly tolerated in these neonates. So, this should be avoided. Post-operatively, uh, majority of the patients are ventilated post-operatively, especially if the esophageal repair is under tension. It is critical to secure the nasogastric tube or the anastomotic tube post-operatively. With TEF are present the vectoral associations, which are the vertebral anomalies, which accounts to 15%, that is hemivertebrae scoliosis. The anal anomalies, that is 25%, like imperforate anus or cloacal deformities. The cardiac anomalies, 25 to 30%, which are VSD, TOF, PDAs, AST, etc. Then the tracheoesophageal fistula and esophageal atresia. Renal anomalies accounts for 24%, like renal agenesis, dysplasia, Potter syndrome, horseshoe kidney, etc. And the limb anomalies include the radial dysplasia, absent radius, polydactyly, syndactyly, and the tibial deformities. 20 to 25% of infants with esophageal atresia have at least three of the above bacterial lesions. Some specific points to be kept in mind in case of typhus. ET tube positioning, it should be done below the fistula and above the carina. Right main stem intubation is done, then the tube is withdrawn slowly just until bilateral breath sounds are heard. Cuffed ET tube without the Murphy's eyes and bevel facing anteriorly is placed, so posterior wall occludes the fistula. Now, and if the fistula is too close or below the carina, then selective bronchial intubation and one lung ventilation is preferred until the fistula is ligated. Some special points: we should avoid extension of the neck to minimize the tension on the anastomosis. Early extubation is desirable to avoid the pressure of ETT on the suture line. Distance between between lip and the site of esophageal repair is measured to avoid suctioning too deep. The next is gastroschisis or omphalocele. Omphalocele is herniation of the viscera into base of umbilical cord. This defect is covered and is midline. 50 to 75% with omphalocele have other congenital anomalies, and the associated syndromes are Beckwith-Whitman syndrome, pentalogy of Cantrell. Incidence is 1 is to 5,000 deliveries, and male is to female predominance is 2 is to 1. The basic mechanism is failure of the gut to return from the yolk sac into the abdomen during the first trimester, which occurs earlier than gastroschisis. Bowel is usually covered and morphologically normal. It's a central defect larger than 4 centimeter in diameter, always covered by sac with where the umbilicus inserts usually contains a liver, midgut, sometimes spleen and gonads. GI tract may have a malrotation, stenosis, atresia, or Meckel's. Cardiac anomalies in such patients includes VSD, TOF, ASD, ectopia cordis, and genitourinary anomalies include bladder extrophy, hypoplasia of kidney, craniofacial anomalies like cleft lip and palate can be present in such neonates. Gastroschisis is typically not associated with other congenital anomalies, just like omphalocele. The GI anomalies in gastroschisis is gagioileal atresia, which is 10 to 15%, stenosis, autoamputation, strangulation, and bowel malrotation. Incidence is 1 is to 2,500 deliveries, which is more common. Male is to female predominance is 1 is to 1. This develops later in the fetal life after abdominal contents have returned into the abdominal cavity. Typically, the right, typically at the right of the umbilicus. And normal umbilical artery insertion is normal due to occlusion of the right omphalomesenteric artery. So this defect develops. Generally, this defect is small, that is less than 4 centimeter abdominal wall defect. This is uncovered. Bowel is inflamed, edematous, for shortened. Midgut is herniated through this defect. Some of the teratogens associated for this defect is maternal aspirin, pseudoephedrine, acetaminophen, and smoking. For both of these conditions, the preoperative preparations are herniated viscous is wrapped in a sterile dressing. One should maintain normothermia in patient. Nasogastric tube is kept in place. Antibiotics to be administered. We should assess the fluid status because such patients are prone to significant fluid and protein losses, which is more in gastroschisis than in omphalocele. Replacement should be done strictly. That is more than 100 to 200 ml per kg of fluid should be targeted. Um, uh, there is this repair is not urgent unless the bowel is compromised. Interop considerations are induction should be awake or rapid sequence induction can be done. Monitors, the routine monitors with arterial lines, CVP, central venous pressures, Foley's, intragastric or bladder pressure should be measured, monitored. Nitrous oxide, nitrous oxide should be avoided. One should carefully watch for CVP, airway, and other pressures as as the closure proceeds, and plan on post-operative ventilation. Post-operative considerations include post-operative ventilation due to pulmonary compromise and the need for an NMR, neuromuscular relaxant, a TPN dependent. Early complications in such surgeries include necrotizing enterocolitis, renal insufficiency, PDA, cellulitis, or breakdown of the abdominal incision. Coming to the next emergency is pyloric stenosis. The procedure to be performed here is splitting the pylorus muscle longitudinally down to the mucosa. The anesthetic technique here preferred is general anesthesia with IPPV. Preoperative assessment, the incidence here is 1 is to 350 births, more common in firstborn male. 80% male, 80% are male, and 10% babies are premature. Clinical features include biochemical abnormalities, notably hypochloremic alkalosis. Maybe the neonate may be dehydrated. Operation is not urgent, never urgent. Full resuscitation should be done first. Electrolytes, particularly chloride and bicarbonate, and pH should be within normal limit, and chloride should be more than equal to 100 millimoles per liter. Perioperative management includes uh, the risk of pulmonary aspiration is more in such patients from the gastric outflow obstruction. A nasogastric tube is mandatory and will be in situ. Nasogastric tube is aspirated and should not be removed. This does not reduce the effect of cricoid pressure and may act as an escape valve if mask ventilation increases the intragastric pressure. IV access is usually in place to consider RSI plus or minus the required pressure if there is excessive nasogastric loss, which is more than even 2 ml per kg per hour. Fentanyl is used with a dose of 1 micrograms per kg with IV PCM, local infiltration of 1 ml per kg of 0.25% bupivacaine with plus minus adrenaline is to be given pre-incision. Laparoscopy can be performed, and in that case, a rectus sheath block can always be considered useful. Patient should be extubated awake in left lateral position. Post-operative considerations, one should remove the nasogastric tube at the end of the procedure unless the mucosa is breached. PCM to be given regularly, and post-operative morphine, prorinata. Feed can be given within 6 hours, but IV fluids maintained until feeding is established. Uh, Special considerations in pyloric stenosis are resuscitation with 5% glucose. Basically, the electrolyte balance should be maintained. That is, resuscitation with 5% glucose, 0.45% NaCl plus 20 millimoles per liter KCl if bicarbonate is less than 32 millimoles per liter. More severe cases may require 0.9% of NaCl. So one should replace the nasogastric losses with 0.9% NaCl. Coming to the next emergency is intussusception. The procedure to be performed is a reduction of invaginated bowel. The technique here is RSI plus IPPV. Preoperative considerations. This is the most commonest cause of obstruction in infants over 2 months of age. The incidence here is 2 is to 1,000 births. Invagination of a bowel into adjacent lower segment, usually at the terminal ileum or the ileocecal valve. Rarely, this can be caused by a polyp or Meckel's diverticulum, which is just about 5% of the cases. Clinical features here: patient presents with paroxysmal pain, blood, and mucus in stool. That is the red currant jelly stool. Uh, uh, the imaging sausage shaped mass in the right abdomen. 70% of the cases are reduced by air or barium enema. Child may be profoundly in shock. Urgent fluid resuscitation with gastric decompression and electrolyte correction will be needed, and blood may be required. Delay can result in perforated or necrotic bowel. Fluid loss may be greater than expected. Perioperative considerations include the rapid sequence intubation and retaining the nasogastric tube in situ. Fentanyl with a dose of 2 to 5 micrograms per kg plus volatile agents can be used. 2 cannula of adequate size CVP line to be monitored in severe cases. Routine monitoring, apart from routine monitoring, temperature monitoring and urinary catheters should be in place. Prolonged intussusception with gut ischemia requires resection anastomosis, can lead to metabolic acidosis and septic shock, and patient can always land in NICU. NICU would be required in such surgeries. Post-operative considerations, for post-operative pain management, a tap block is preferred. A wound catheter or drain should be placed. Local wood infiltration should be done, and morphine to be given for post operative analgesia. Special considerations in such cases are, these children are very challenging to deal with, as they have had very unsuccessful barium enema or air enema, both with sedation. They may be inadequately resuscitated, so venous access is often challenging, and a significant resuscitation is often necessary. That's it from my side. Thank you so much.
Congratulations for a very lucid and exhaustive presentation. For a first year student, it is really heartening to see that you have taken so much pains to prepare this answer. One question I would like to ask here is, did you prepare it on your own or you took guidance from some seniors?
Sir, I took guidance from my seniors as well.
Okay. So the question, what can you repeat the question? What is the question that we have asked?
Sir, it's anesthesia in neonatal emergencies.
Anesthesia for neonatal emergencies. Very good. So what is a neonate, first of all? Have you ever defined what is a neonate in your answer?
Sir, in my answer, I have not defined neonate.
So now can you tell me what is the answer for how do you define a neonate?
Sir, it's 37 completed weeks of period of gestation. So, yes, sir.
That's a neonate. So if a baby is born at 37 weeks, it is called neonate, is it? Is that the way it is defined? Supposing
Sir,
one baby is born at full term 40, what will you call it?
sir,
Infant?
yes, sir. There's also early neonate and late neonate.
No, early neonate, neonate and all that. Okay. Any child with 44 weeks of post gestational age is called a neonate.
Neonate.
Okay. Supposing a child is born at 37 weeks of pregnancy, up to 44 weeks, it is still a neonate. Another 3 weeks and plus 28 days, 4 weeks, it will be only a neonate. On the contrary, if a baby is born at full term, 40 weeks, from the date of birth to 28 days after delivery is also called a neonate.
Neonate. Yes,
So
sir.
it is better to remember that it should be until the usually earlier books used to say first 28 days of the birth after delivery is a neonatal period, but because it does not define whether the baby is born at full term or the prematurely at 37, 38 or 39 weeks. So all the babies up to their 41st week of the post-gestational age, they are called neonates. Okay.
Yes, sir.
So no, not 44 weeks because 28 days after birth. So up to 44 weeks of post gestational age, that is from the time they got conceived up to 44 weeks, they are called neonates. Okay.
Yes.
And these neonates have some emergencies which are life threatening, which have to be immediately operated as soon as they are born.
Yes, sir.
So they are called emergent neonatal emergencies. If you don't do it rapidly with preparing the baby as quickly as possible and take up the child, you cannot salvage the child. There are some surgeries which are present in the neonatal period, which exhibit in the neonatal period. You can optimize the baby to some extent and then take them up for surgery and correct that defect. That is called urgent neonatal emergencies. So first thing you have to classify a neonatal surgical emergency into emergent surgeries and urgent surgeries. Emergent surgery means it's life threatening. It has to be done as rapidly as possible. Whereas an urgent neonatal emergency surgery is one which is to be done faster, but you don't have to hurry through. You have some time to optimize the baby and then take up the baby for the surgical procedure. So these two have to be first defined in your answer. What is the definition of a neonate and what are the types of emergencies you encounter? One is emergent emergencies and another is urgent emergencies. Okay, and you have
Yes.
varieties of examples of type neonatal emergencies that are there, some of which you have mentioned also. Now coming to the next point in your, you correctly started with what are all the general principles in the management of a neonate, like history taking, examination, investigation, all the things. But there are certain peculiar physiological differences between an older child and a newborn or a neonate, which have to be mentioned in detail before you go into the regular method of history taking, examination, investigation, preparation, intra, post-op management. And the issues of concern which are there for the neonate are first and foremost is thermoregulation. The neonate, they don't have a control over their body temperature maintenance. The first thing they undergo is they can become hypothermic. So you have to first take care of the sorry, discuss about the hypothermia they are prone for. The second thing is their glucose metabolism. They don't have, why they are likely to become hypoglycemic more commonly. What is the reason for a neonate which is likely to become hypoglycemic rather than hyperglycemic commonly? What are the differences between an older child and a newborn or a neonate with regard to glucose homeostasis in the body?
Sir, immature liver.
Mature liver, very good. So what does it do? Do they have glycogen like an older child or an adult? Glycogen storage? Can they
No, sir.
do gluconeogenesis?
No, sir. No, sir.
These two processes are not there. Okay,
Yes, sir.
the glycogen storage is very limited, and neoglucogenesis is also not taking place. So, because of these two reasons, the newborn or a neonate is more likely to become hypoglycemic due to starvation or loss of fluid like vomiting and other things. So, that is the second important issue. The third thing is their cardiovascular system. What is the peculiarity of their neonatal circulation? How does it become? What is the difference between a fetal circulation and a neonatal circulation? When the baby is in the womb, inside the uterus, how does the circulation differ from the circulation of a neonate? Does the blood flow through the lungs when the baby is inside
No,
the
sir.
womb? So how does it receive the oxygen for the metabolism and growth as a fetus inside the mother's womb?
Sir, the umbilical.
The placenta is the main source of oxygen delivery
Yes,
and carbon dioxide elimination because
yes,
the
sir.
lungs are not functioning and until the baby is born and starts the first cry, right?
Yes, sir. Yes,
Okay.
sir.
So the blood that is coming to the right side of the heart, how does it reach the left side to get pumped out into the aorta and the major vessels?
Sir, foramen ovale, and then
There is a right to left shunt
right
inside
to
the
left
heart,
hand. Yes,
intracardiac. Sorry, right to left shunt. So, so how does that get closed, and how does it uh, get managed, get converted to the neonatal or an adult-like circulation?
sir.
When the lungs open and the pulmonary circulation opens, what should happen? The right to left shunt should close, and
Yes,
the blood should flow through the pulmonary vessels
pulmonary.
and come to the left side of the heart. Okay,
Yes,
the
sir.
foramen
Yes,
ovale will automatically close because the left atrial pressure will increase and close the communication between the right and the left atrium. Okay,
yes, yes, sir.
and the another communication is the ductus arteriosus. That is the
Addresses.
blood that is going through the aorta also has a communication with the pulmonary branch, pulmonary arterial branch in the fetal circulation, isn't it?
Yes,
So
sir.
these two communications have to close. But do they close immediately after birth once the baby starts breathing and the pulmonary vessels open out and the pulmonary pressure, vascular resistance comes down? Does it uh, remain like that afterwards, or can it get back to the fetal type of circulation?
It doesn't close immediately after the.
So there is always a chance of the circulation reverting to the what is called the fetal type of circulation again. What
Yes,
are
sir.
the causes which will cause this particular problem of reversal from the adult type to the fetal circulation?
Sir, lung immaturity, premature in preterm babies.
No, not immaturity. Supposing there is hypoxia or acidosis, okay, and hypovolemia. All these things can
Uh,
convert or revert the adult type of circulation into fetal type of circulation.
yes, sir.
This type of reversal is known as flip-flop or yo-yo circulation. This is a
Circulation.
very, very important point you have to discuss about when you talk about the neonatal anesthesia. Okay? Then, of course, there is immaturity of the liver function, immaturity of the renal function. The renal function is not completely mature enough until the age of 3 to 5 months. Okay. So, what is the difference in the proximal tubular function of a neonate compared to an older child? It doesn't reabsorb sodium like a normal adult kidney. The
Yes,
proximal convoluted tubule of a neonate is immature and it cannot reabsorb the sodium that is filtered from the glomerulus. So they lose sodium rapidly and become hyponatremic much more faster. Okay,
yes,
so
sir.
that is one of the more important complications you have to anticipate in these patients and make sure that they don't suffer from lack of sodium. And with regard to the central nervous system and the peripheral nervous system, what is the main important thing in the neonate? Is the myelination complete and the baby is up to 44 weeks of post-gestational age?
No, sir.
Myelination is not complete. So
Not
when the myelination is not complete, what are all the effects because of that nervous system? The reflexes are not fully developed. Okay?
Yes, sir. Yes, sir.
And the nerves are very sensitive. So even
Yes.
a very low concentration of local anesthetic agents will be able to block them. Okay.
Yes.
So these are the 2 points that you have to remember, and their blood-brain barrier is also not well developed. So they
Yes, sir.
can also get affected, and toxins can go through that and affect the cellular system also. Okay. So all these various systems first you have to describe, and then go on to the method that you have chosen, and then finally come to the various emergencies that you come across, which you classified as thoracic, abdominal. That is one way of classifying that. Another way of classifying, but the correct way is to do emergent, urgent, and another way some people accept is those which require intervention within the first week, first 3 days of life, first 1 week of life, first 10 days of life, like that. And finally, what you described into intussusception does not belong to the neonatal emergency because it happens in an older baby, like a 5 months old or a 6 months old baby. So that doesn't come under neonatal emergencies at all. Okay.
Yes.
So the
Okay, sir.
common neonatal emergencies that you have to remember are the tracheoesophageal fistula, which can be life-threatening, congenital diaphragmatic hernia, if there is associated pulmonary hypoplasia, and necrotizing enterocolitis, which can kill the baby immediately, intestinal obstruction, which is also life-threatening, and of course less emergent natures, as you said, as pyloric stenosis, the gastroschisis and the ampulocele and all those things come under less emergent nature of that. Okay, so but I appreciate you for preparing this even with the help and presenting it in a very lucid fashion. I'd just like to share. Dr. Venkateswar Rao, are you there?